Welcome to the InTouch Health webinar series. This is Scott Young, and I'll be your host for the webinar today. Today we'll be featuring Dr. Herb Rogove of InTouch Health, and he will be presenting on telehealth reimbursements. Dr. Herb Rogove, Chief Medical Officer at InTouch Health, has over 30 years' experience directing and establishing ICUs and intensivist, hospitalist, and emergency medicine programs in the academic and community hospital settings. In 2008, Dr. Rogove formed C3O Telemedicine, where he oversaw the implementation of multiple telemedicine programs and has become a leading expert in the delivery of telemedicine and its clinical application to critical care, neurocritical care, stroke care, hospitalist, and psychiatric care. He has also held numerous leadership and administrative positions at major health tertiary care facilities throughout the United States. Trained at the Cleveland Clinic and the University of Southern California, he has held faculty appointments at the University of Southern California, University of Pittsburgh, The Ohio State University, and Ohio Health. Dr. Rogove's experience and relationships have led him to be considered nationally as one of the pioneer providers of telemedicine, and he speaks regularly at national telemedicine conferences. In 2012, Dr. Rogove was nominated and voted onto the board of the American Telemedicine Association, the nation's leading advocacy group and resource provider for the field of telemedicine. He is also on the editorial board of the journal Telemedicine and eHealth. Dr. Rogove is a fellow in the American College of Physicians, the American College of Critical Care Medicine, and the College of American Telemedicine Association. We will begin our webinar shortly, but first, a few notices. You have all been auto-muted. If not, please make sure to mute yourself. At the bottom of your audience console are multiple application widgets you can use. If you have any technical difficulty, please click the Help widget. It has a question mark icon and covers common technical issues. You can expand the slide area by clicking on the Maximize icon on the top right, or by dragging the bottom right corner of the slide area. During the webinar, you'll be able to enter questions in the Q&A widget located on your audience console. Questions will be answered at the conclusion of the presentation, so please feel free to ask your questions at any point throughout the webinar. If a fuller answer is needed, or if we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website. This webinar presentation should last around 30 minutes, including time for questions and answers. And now, without further ado, here is Dr. Herb Rogove.
Well, thank you, Scott, and good day to everyone. Welcome to a very rapid introduction to billing and coding for telemedicine. I'd like to start by prefacing my comments by stating that we are in a constant state of flux where new codes are being introduced, clarification is a must, and confusion is to be assumed. So without further ado, let me start with the first slide here. So our objectives for today will be to talk a little bit about the domains of reimbursement, know your geography, trying to make sense, if at all possible, with Medicare, and a little bit about the other providers, and essentially what's happening in 2017. Well, if you're a big fan of Game of Thrones, you understand about domains. And this afternoon, we're going to be talking about predominantly CMS, Medicare, but also have to mention Medicaid. I'll just briefly mention the VA only because it's not only an extensive service, but it serves as an excellent standard for telehealth. And then finally, the private providers like the Blues, the Aetnas, and the Humanas. So the first step is to really understand geography, and I'm going to present two slides with maps. The first one has what we call the MSA, the Metropolitan Statistical Areas, also known as the urban areas, versus the non-MSA areas, which are micropolitan areas, or better known to most of you as rural areas. As you can see in the green and the tan, those are the areas that are considered metropolitan statistical areas. Big cities like New York, Los Angeles, Chicago, and that could be equated with essentially Medicare does not, and I emphasize does not pay for Medicare in those locales. Medicare mainly pays in the non-MSA areas. Now, the second area basically is designed to show you where most physicians' providers are located. If you're in a green, orange, or yellow area, those are what are designated as underserved areas. And as you can see, going back to the large cities from Los Angeles to Chicago to New York, those are areas that are in gray. And I mention this is important because that's how Medicare is derived, which sites and the locales are being paid for Medicare or not being paid. So let's take a look. This is a checklist or the steps that are necessary for you to be able to bill for Medicare patients. The service has to be through an interactive telecommunication system. Translated, that means live audiovisual system. Secondly, it has to be provided by an authorized practitioner, and we'll later define what that means. Third, one must be an eligible telehealth patient. And I mention this because most Medicare providers will show you that, again, if you're in a non-MSA area, you could be paid for it. For private, it's important for you to check your policy to see if you might be qualifying for telehealth visit as well. Next, you must be a telehealth originating site. For those of you that are already familiar, originating site is where the patient is located, a site where the provider is considered the distant site. And then finally, you must utilize the appropriate codes. And there are two types of codes. Number one, the CPT codes, which were developed by the AMA, and what also known as a HCPC code, the second type of code, which are the Healthcare Common Procedural Coding System codes. And this was developed by CMS. Additionally, you need to know that if the patient is being seen live, which we recommend, it's a GT modifier. If it's asynchronous, it's a GS modifier. Asynchronous currently is only being paid, and I'm going to reiterate this several times throughout the course of this discussion. GS, asynchronous, is only allowed in what we call demonstration projects under Medicare. And these are usually right now only in the states of Hawaii and Alaska. Another important modifier, which was just introduced January of this current year, is the place of service, POS, with a number 02. And that could be applied to originating or distant site. So what we're seeing a pattern here is that Medicare and the privates are now giving us modifiers that designate and differentiate between an on-site visit and a telehealth visit. Next, the bill must go to a Medicare administrative contractor, also known as MAC. And the reason is that in each state or region, Medicare has elected carriers to provide the ability to process claims. So the carrier in California is different from the carrier in Illinois or Minnesota. Also, a couple tidbits. If you are a critical access hospital and decide to bill on behalf of your physicians, that means the physician has to assign or reassign his or her billing rights to you to be able to bill. Keep in mind that Medicare will only reimburse 80% of the usual professional fee provided by the physician. And then finally, on the billing steps, one needs to know that you have to be a Medicare originating site, again in the non-MSA area, to be considered eligible to collect the facility fee. And that code, a HCPC code, is Q3014. And now that could be billed per patient on a daily basis. And again, keep in mind this is a very small amount of reimbursement, $24, $25, for you to help defer some of your technology costs. So, who can be considered a provider for CMS? Not only physicians, but nurse practitioners, PAs, midwives, clinical nurse specialists, psychologists, social workers, nurse anesthetists, and nutritional professionals. How do we know what kind of codes to use? Well, on this slide, you see CY 2017. This is the Medicare Telehealth Services codes. In the left column are the services, and the right column are either the HCPC code or the CPT code. And for those of you that have any familiarity with coding, you can see these codes are the ones you currently use for on-site care. Keep in mind, in 2016, there were probably about 40 codes. In 2017, we're now over 70 codes. So the trend is very, very positive. Now, what do you consider an originating site? This is a requirement to be paid. Well, it can not only be a physician office or a practitioner, but it could be an in or outpatient, a critical access hospital, a rural health clinic, FQHC. It could be a critical access hospital, a skilled nursing facility, or community mental health. This is the HRSA site. This is where you go if you want to make sure that you're eligible to be a provider and your location is considered a non-metropolitan statistical area. So if you either Google HRSA or in the top right corner, it has the URL, and again, you'll get a copy of this. You'll be able to put in your zip code and find out if you're eligible as a Medicare provider. So what's big in 2017? I would say 3 areas. One, dealing with end-stage renal disease and our list of codes there that are not totally inclusive. So now we're considering, well, not only at dialysis centers, but hopefully soon home dialysis might be considered to be able to be a telehealth reimbursable code. In the intensive care unit, we have a brand new code, a HCPCS code, G0508 in 09. The 508 is analogous to the 99291, which is a critical care code on site. This new G code is for the first 60 minutes. The 0809 code is for the second 50 minutes. So you're talking about 110 minutes of critical care, which obviously is a very highly complex, very difficult patient, spending a lot of time, and you can be reimbursed for that. Again, making sure that you realize it's in the non-MSA areas. And finally, just to repeat, the point of service code of 02 is the telehealth code that was introduced in January of this current year. Here's a couple quick examples. There's a new modifier, 95, and this is for the non-Medicare patients. So let's say a patient is seen in a subsequent hospital visit as indicated over the picture. It's a 99232 code. And now what we add, since it's a telehealth code and a non-Medicare patient, you add the modifier 95. And that means it's a real-time, synchronous telehealth service being rendered. Now there's an Appendix P that goes with modifier 95, and it really tells us that it could be used for many, many different services and clinical specialties. Psychiatry, pharmacy management, detection of retinal disease, cardiac monitoring, behavioral health, nutrition, office, subsequent visits, inpatient consults, behavioral health. One can find that under modifier 95. Now, what happens if you're a Medicare patient? Unlike the 95 modifier, we use the 99232, but now we use the GT. The GT, as we mentioned earlier, is interactive real-time video conferencing. And this GT is something now that the POS 02 was just introduced, maybe the GT's lifespan is limited because basically what we're seeing with the 02 might replace that because it really distinguishes, again, whether it's on-site versus telehealth. And as I had mentioned to you previously, the GQ code can only be used in demonstration projects which currently are only in, again, non-MSA areas in Alaska and Hawaii. So I'm going to conclude with a little bit about what's happening. What about Medicaid and private payers? As you can see on this map, everything in gray is Medicaid only. Everything that's in blue includes Medicaid and private payers. And I'm happy to report as of last year, the state of Rhode Island is now included in the rest of the 50 states. So we can comfortably say that Medicare and private payers now occur in all 50 states. And that comes up the idea of the issue of the ability to be able to bill. Keep in mind that the states determine how much they bill. In other words, not everyone's going to get 100% of Medicare. So you have to be very careful when you interpret the parity laws because not all parity laws are equal. And then finally, to give you all some hope out there, recently the Chronic Act, which was Senate Bill 870, was just passed. And that includes telestroke, accountable care organizations, Medicare Advantage, end-stage renal disease, and also home demonstration projects. In the right column, you can see the effective date. It won't occur immediately. Keep in mind that it passed the Senate, so it has to go to the House of Representatives. That bill is the FAST Act, which is purely telestroke. The Chronic Act includes telestroke as well as some of the other parts of the bill which are listed there below. So the reality is it's very optimistic. I'm very hopeful. I think in the last couple of years we had a lot of false starts, lots of legislation being introduced both at the federal and state level, but I think this is a huge and giant step. So at this point, that's the conclusion of my formal presentation, and let's open up the lines for questions and answers.
Great, thanks. So yes, we will begin the question and answer portion of our webinar now. We'll give a few moments for some questions to trickle in, so please make sure you get your questions through the Q&A widget located at the bottom of your console. All right, so we got one right now. So what are some good resources for information on reimbursement?
Great question. I think some of the slides, the CMS website, if you do a Google CMS Telehealth, is great. The American Telemedicine, I can't speak highly enough. Obviously, I have a bias, but I've been watching what they've developed. Gary Capistrant and Latoya Thomas have done an excellent job and are a tremendous resource and very receptive to any questions, and can help you put you in the right direction.
Great. Okay. Here's one. When billing an inpatient TM visit, must the admission date be included on the HCFA?
Yes. Admission date must be included. The more details you have, filling out that form is extremely important. So, yes.
Alrighty. Medicaid and other payers is still quite broad. Can you narrow down the state by whether or not it's public aid and or private payers to cover telemedicine?
Well, it depends on what state you're in. The private, as I alluded to on the map, probably over 31 states now have parity laws. So you really need to check. Again, the ATA has a great list, and they've gone through each of the states, breaking down which states pay, when they paid. And you probably have to check again with your carriers, both your private payers as well as your Medicare payers. But in particular, private, if you're going for the privates, to see what they reimburse and what the reimbursable rates are.
Excellent. We'll give it a few more moments, see if any final questions trickle in. Here we go. Do you have a sense for how credentialing, authorizing providers to perform telemedicine out of the originating state is changing? And do you anticipate a day when there will be a reciprocity across states without having to credential in each state?
Oh, that's a great question, a complex question with not a great answer. Credentialing is really a major problem along with interstate licensing. The Joint Commission came out with proxy credentialing, and the experience I've had in multiple states and with different healthcare systems, individual hospitals are not buying into it even though they're part of a health system. And, I would hope that the American Hospital Association, in conjunction with the ATA, can kind of push that credentialing because, again, I think it's a priority equal to what we're seeing with interstate licensing.
Excellent. Here's one. In setting up a new telehealth service, i.e. follow-up visits, what are critical things to think about related to setting up realistic metrics to achieve?
Let me take a look at that again. I'm not sure I understand that question.
We can go ahead and answer that one offline then and move on.
Yeah, let me. You could provide some more details on that because the follow-up visit's very broad. As far as the metrics, are you talking about pre-established metrics, rules and regulations? Obviously, Medicare has rules for that, so.
We can answer that one via email after.
Okay, that'd be great. I appreciate that.
Excellent. Can providers still bill a consult code if the facility does not qualify as an originating site? I've heard that some facilities are billing the consult code without the modifier.
Right now, since they have introduced, as I said, this past year, you must have the modifier. Whether the individual state, the Medicare provider, decides that when they process the claims, but I would highly advise that you follow the regulations as stated because they're going to definitely enforce that. As it is right now, they're only paying about 20% of the people that are eligible. So again, the rules are there for a reason, and I highly suggest that they follow to the T.
Great. What is your opinion about the future of value-based care models?
Well, I think that's where we're going. I think we're seeing more and more value-based. You know, as it is right now, some of the discussions about telehealth is they talk about bundling telehealth. We're not too sure how it would play out, but value-based care is here to stay. Fee-for-service is decreasing. I think the demonstration projects have shown that money can be saved, and those ACOs that have participated have actually received bonuses as a result of that. But overall, millions and millions of dollars have been proven to be saved by value-based care. Now, the one thing that I'm always looking for is have the outcomes as far as patient outcomes. I haven't seen too much on that. It's great to save money, but we want to make sure it's saved money not at the expense of patient safety and good outcomes. So stay tuned for that. I'm highly encouraged that it's going to be positive, but we really need to stay alert and awake for what's coming along.
Excellent. All right, so the next one, Medicaid will pay for psychotherapy CPT codes provided at the psychiatrist, but not the psychologist. What has to change in order for this to change, and is legislation needed to change this?
Well, again, Medicaid is for each individual state, and Medicare has set the example of saying that psychotherapists, clinical psychologists, again, in the non-MSA areas, they are eligible, they're considered providers. So I would check with your state Medicare person to see exactly why you're not being paid, and to, again, lobby. And I think, again, one of the take-home messages for the audience out there is you have an important responsibility. If you want to see payment, you really need to lobby your own state legislatures, and it's not too bad for you to consider lobbying the federal legislators as well.
Okay, excellent. And this next question is talking about Medicare again, saying, I heard you say Medicare is reimbursing at 80% the professional fee. However, this specific individual has been seeing reimbursement based on 80% of the facility rate, which is approximately 25 or 30% reduction compared to 2016. Do you have any comments on that?
Well, again, that's a Medicare regulation. I'm not sure. It would be interesting to learn from you where you are and specific details related around that, but you should be paid. Again, it's a critical access hospital in a non-MS area that I was referring to, and hopefully that did not confuse your question there.
Okay. Do you have an opinion about how CMS is compensating based on populated/urban areas versus underserved areas?
Well, Medicare, again, the physician part component, they're not reimbursing for urban areas, and that's why we're hopeful for the legislation. As far as the payers themselves, I could speak here in California that they do reimburse at reasonable rates. My experience has been with telestroke. They do that. So again, you need to check which states have parity and if they're going to be paying in your particular state.
So on a follow-up to that, in your opinion, does this disenfranchise small community hospitals that exist in large urban areas but don't have specialty services, or do you think they could still benefit from telemedicine?
Oh, absolutely. They definitely benefit from it. Unfortunately, the burden right now are on those small hospitals. But again, the other option is if you can't take care of those patients, you don't have the specialists to care for them, and what happens? You end up transferring those patients away from your facility. So at this particular point, I'd highly encourage to take a look at the risk benefits, the ROI, and in most cases, I think you're going to find a very favorable ROI and certainly an improvement in the quality of care.
Okay, great. Can one organization be the originating and distant site if contractually we collect the pro fees?
That would be a tricky one. If you're part of a healthcare system, I can understand where you could be the originating and then the distant site, but to be considered the same, I'm not aware of any cases where that's occurred successfully. So if anyone out there in the audience knows of such, it would be great to share with all of us.
Okay, excellent. I'm not seeing any more questions, so I want to go ahead and give a big thank you to Dr. Rogove. Oh, actually, we got one more coming in. I'm sorry.
And I appreciate all the great questions. I think they're on everyone's mind, and it's great to be able to share. And again, as I mentioned earlier, it's very nebulous right now. We're just starting to get some experience, and hopefully it'll become more robust.
Okay, so the final question.
Okay.
I have a hospital that is not in an MUA because of its proximity to a large metropolitan area. This hospital itself is only 24 beds with very few specialties. Is there any way to argue or change the hospital designation?
Well, yeah, I think that's a great question. It's something I've seen raised before, and I think that's something you really need to talk with the folks in your state. Again, that's a tough one. If you're close to a metropolitan statistical area, you may not obviously be able to bill. But again, this comes down to the grassroots lobbying efforts. So would not give up hope, but definitely pressure and connect with your local representatives.
Okay, great. And then do you have any advice on how to influence providers that are resistant to telemedicine?
Providers that are resistant. Well, I think there's evidence both in the medical literature, in the medical literature out there that shows that there's tremendous benefits. And obviously, we continue to publish studies, but I think that everyone is becoming on board. The VA, they've got some great experiences, and I think we're starting to see now that if the AMA is behind it and all the professional societies are behind it, I think it's here to stay. And I know the most difficult is convincing providers to get on board, but once they see it, experience it, and have the data to show that it's highly effective, then the case is won.
Okay, great. So once again, a big thank you for Dr. Rogove for today's presentation. There were plenty of questions today, but if you had any additional questions or for more information, please contact us at feedback@intouchhealth.com. And also, please visit our website to find a recording of this webinar and a list of upcoming webinars in our series. This concludes today's webinar, and thank you for attending, and have a great day.